prevention in adult cancer survivors. Thank you.
Thank you for the invitation, and hard act to follow after fascinating basic science. I will also try to, at least at the end, to connect things with some basic science issues, perspectives, but I was challenged with an interesting case, which I will shortly present. We of course know that a lot of cancer survivors die from cardiovascular disease, and the cardiovascular diseases become the major issue. And the more cancer survivors we have, the older they are, the more risk factors, the more that we will have to deal with these issues. And the numbers may differ between the papers, but this is obviously a major issue. So Zaza challenged me, and I thank you for the good idea for presenting this case. It's a 70-year-old woman that was diagnosed with left breast cancer with the following stages, as you can see. And she was treating according to a pretty standard protocol and received cyclophosphamide, and then she underwent lumpectomy, again, chemotherapy. She received chest radiotherapy, 30 sets, and Taxol as an additional 12 rounds. She has some basic risk factors, as expected perhaps from a 70-year-old lady. Not surprising, have hypertension. She has a mild LVH per echo. Her baseline echo had a normal ejection fraction without any regional abnormalities. She has a mild left atrial enlargement. Again, mild left atrial enlargement would not be something that would be unexpected. She has a pretty unfavorable BMI, and we know that BMI, of course, is correlated both with cancer appearance, but also correlated with outcomes of cancer patients, and not favorably, obviously. And she has impaired fasting glucose. Her A1C is as follows. You can see the labs. Nothing to write home about, apparently, but it's we'll see that it's not exactly the case. Her LDL increased during the period she was treated, with at least transient reduction in her HDL. Triglycerides also increased during treatment. She's now at a pretty good number. Normal TSH, glomerular filtration estimations, and she doesn't have microalbumin in her urine that has been tested. And the next question is what should we do next? What should we do next? Because we know that she's under a certain risk. I'm not sure we know to quantify this risk correctly. Obviously, we know that her treatment has some significant potential implications. Her chest was irradiated. She received alkylating agents, cyclophosphamide, with obvious and known and established cardiotoxic effects on cardiac myocytes, but also potential risks for thromboemboli. And she also received Taxol, with major risk being bradycardia, but obviously not only. And we have to consider these elements. The literature states risks that vary very widely. So is she on the safer side or on the higher side of alkylating agent potential risks? Again, relatively low risk, long-term risk with Taxol. But we know that there is a significantly increased risk for thromboemboli, demonstrated in a number of studies. And she also has a coronary potential disease. So we're dealing with a really complex interplay here. It's the interplay between native risk factors, some of them genetic, some of them, of course, age. Some of them are related to the basic risk factors of cancer. We know that there is this complex interplay between obesity, impaired fasting glucose, metabolic syndrome, including low HDL, waist circumference, hypertension, and a whole milieu that is a really inflammatory milieu. We know that obese patients with diabetes have higher levels of IL-6. They have higher levels of TNF. Then all of these factors are potentially implicated in the pathogenesis of the origin of the cancer. But they also probably are related with future risk for cancer recurrence, because we know that obese and diabetic patients have a higher risk after breast cancer cure, so-called. They have a higher recurrence rate. And it's same for colon cancer, same for prostate cancer. Cancer recurrence rate is also related to energy balance and the amount of physical activity our patients are doing. And you've seen the BMI. She's probably not that active, and obviously she has impaired fasting glucose and additional metabolic abnormalities. On this substrate, we add our goodies. Goodies being chest irradiation and the different types of chemotherapy. So what should we do next? The guidelines for primary prevention, European Society guidelines, are not specific and are not detailed, that's an understatement, regarding these patients. So should we manage these patients as very high risk, as we manage diabetes with another comorbidity like hypertension? Should we manage them as high risk, like diabetes alone? We're not sure. How should we continue? Her main complaint is fatigue, exercise intolerance. And we know that cancer patients have a VO2 reduction, so exercise capacity reduction as we measure it with the gold standard of VO2, oxygen consumption estimation, have 30, 40, even 50% reduction from their pre-cancer state. So is the fatigue perhaps related to a coronary disease? Should we search for ischemia, or should we search for atherosclerosis? And how do we search for atherosclerosis? The guidelines don't know how to search for atherosclerosis even in cardiac or even in regular cardiac patients or pre-cardiac patients with risk factors. They're not clear. They're not clear on the role today of coronary CT, it gets a 2B, ultrasound, IMT, it gets a class 3. It's been thrown out. So what should we do next? Not simple. Hypertension. What's the best drug to treat her hypertension? And of course, how do we manage obesity, impaired fasting glucose, and the dyslipidemia? What are the exact LDL goals? 70, 100? So it's a complex interplay, and a lot of things are now being done without clear-cut, evidence-based medicine that we are used to. But it's the art of medicine, so we can still use our logic and search and try to understand and differentiate different types of cancer treatments according to the risk for coronary artery disease if we're thinking about how to manage coronary artery disease. How do we manage LV dysfunction? When it appears, that's a safer place and a clearer place. So what did we actually do, and what are other options? First of all, hypertension, she's getting ACE inhibitors. That's great, because this patient is a heart failure patient. She doesn't know it yet. But according to the guidelines, although the reduction in her echo was only from 60 to 55, which is not a lot, she's a stage A heart failure patient. The heart failure discipline, almost all of us are at some time or the other a stage A. So stage A is having risk factors. You don't have heart failure, but stage A heart failure, according to the guidelines, is you have some type of risk factor. And she has a lot. She's hypertensive. She's borderline diabetic. She received chemotherapy that led to a mild reduction in the LVEF. So it's great to to give an ACE inhibitor or an ARB, and that's being done. So that's simple. But one common mistake is not to titrate these medications correctly and give a calcium channel blocker. And that's a mistake we commonly see in heart failure patients, that they get a low dose ARB or ACE, and then they get a drug that is nice, but it has no proven effect on disease, as a disease-modifying effect on heart failure. Metformin, I think, would be a very reasonable choice in such a patient with impaired fasting glucose. And if we believe in metformin as more than just a drug given to impaired fasting glucose subjects or diabetic subjects, perhaps metformin has also anti-cancer drug properties. And that has been shown in a number of retrospective studies, and we also have shown this in heart transplant patients that were receiving metformin had significantly lower rates than diabetic patients not receiving metformin. Again, it's a retrospective, most of these are retrospective analysis. How do we deal with BMI 40? I wish I knew. Complicated. And we obviously want to improve the quality of life. Should we give aspirin? Do we give aspirin automatically if you're diabetic? The answer is no. Not all diabetics automatically get aspirin. Do we know that this patient needs to get an aspirin? So it's unclear. It would have been much simpler if I can actually demonstrate that she has not risk, but atherosclerosis. And this we can look for. We can look for atherosclerosis, obviously, carotid arteries. We can look for them in the femoral. We can do a coronary calcium score. She wasn't excited about the idea of getting another CT and some more chest irradiations. So it's a challenge. The simplest non-challenge is giving a statin. Her risk of receiving statins compared to the potential future benefits are obviously outnumbered because she has a lot of risks. So that's the easy step until she at least has the pains, the muscular pains. So what about exercise? And I will elaborate a bit more on exercise, as this is something we're dealing with and studying. Exercise is correlated with better prognosis. That's obvious. But this is a correlation. It's not a clear and obvious cause and effect. And you can see from this large cohort of 53,000 patients that if you meet your recommendations, you are better at cancer mortality. And obviously we know the studies that if you do this before you get the cancer, the chances of getting cancer in active people, not patients, is significantly lower. So I am very happy with the new commercial saying there is a drug, or there is in Hebrew, there is a pill, there is yesh kadur lemeniat sartan. There is a pill for preventing cancer, and that kadur is called kaduregel and kadursal. So this is an important statement that physical activity.
Cancer Association, right?
Yes, very important saying, and not enough said. So some more funding, please. And
it's also done, צעדים מחוסנים in hospitals.
Definitely.
Not only said.
Definitely. And it works. So physical activity, survival after breast cancer, and you can see the graphs. So there's a clear and very clear benefit. It's not easy. Not easy to do, especially during breast cancer treatment. These patients are weak, they're tired. The benefits are clear, but the sad thing about sports, once you stop, everything goes away, and you know it from your own lives. Interestingly, exercise activity not only improves oxygen consumption, functional capacity, well-being, but at least in mouse models, it also increases neuroregulin 1 levels and reduces TNF levels. So perhaps there is also a crosstalk with the previous lectures. And we do have some small studies about patients developing LV dysfunction and being treated with sports, with exercise as an addition to the medications, but these are very small studies. So we need to do a lot more basic science on humans, a lot more clinical studies, preferably on humans. And the complex thing is that the rats in the tests, when they stop exercising, they get a small electrical zits. It didn't pass the Helsinki when we tried this with humans, although we have devices that know how to do this. And I won't go into the details, but we know the Cochrane review showing that physical exercise reduces depression in cancer patients, it increases quality of life, it improves fatigue, and it does all these nice things. Is this the solution? I don't think so. This is cardiac rehabilitation. I don't think that these patients should come to cardiac rehabilitation. I think they should have a specialized, organized, structurized program that they can do in the community. But this has to be supervised. It has to be monitored for efficiency. It has to be correctly done. But you know what's one of the biggest elephants here in this story? Why was this patient referred to the cardio-oncologist physician? Because of her risk factors? No. She was referred because we were occupied and we were looking at the echo. And she was referred due to that small change in the ejection fraction. If that change wouldn't have occurred or it wouldn't have been noticed, this patient wouldn't have received the correct prevention, medication, and intervention she actually got. And she got statins. Her hypertension is now managed. She got metformin. She was sent for a stress echo in order to assess ischemia. This is perhaps not enough because obviously a non-obstructive plaque will not show up on the stress echo, and it can, in the future, obviously rupture and manifest as an acute coronary syndrome, but it's a lot. But the truth is that the vast majority of these patients are not currently recognized as being at risk. And the guidelines are not clear enough. How should this patient be evaluated and how should we consider them? And in a final slide that it's from heart failure studies, but it's highly relevant to oncology or cardio-oncology. These are the known effects of exercise training in heart failure patients, and most of these elements have been studied in humans. These are not rats. And there is a lot of effects here that are very important. And as I've said, upregulation of neuroregulin, but I would like to focus on NO synthetase, endothelial NO synthetase, upregulation and release of NO. And NO is very, very important because of this. Our endothelial cells can go to the dark side or they can go to the light. And what controls part of this internal complicated crosstalk is these sensors. We have small sensors on the endothelial cells that are activated when you go to your gym. And they induce NO upregulation and thrombomodulin, of course, and other key factors. And they push these cells to an anti-inflammatory state, anti-thrombotic and vasodilatory. Finally, I don't recommend this, please don't cite me. When you have higher levels of NO, This releases progenitor cells from your bone marrow. And these endothelial progenitor cells are probably very important, not by being progenitor cells simply, but they also secrete important factors that are probably important also in these cancer patients. So we need to do a much better work at identifying and managing this population. And I thank you for the opportunity to look into this further, and we need to think concretely what should we do. Thank you.